All right, so the next protocol we're going to talk about is the acute coronary syndrome adult protocol. Pretty much the same, but some slight changes. So we'll look at that. So this is the EMT part of the protocol. Not much has changed here. You're still doing your routine patient care. Something notable, instead of just giving everybody oxygen like the old protocol said, um, or I think it was just the old protocol said just to maintain SpO2 above 94. This protocol kind of specifies between 94 and 98%, so just enough to keep them above 94 but less than 98. The reason being is once you get up to 100%, your PO2 can actually be higher than that, and that's not good for uh, patients having chest pain. Still going to give 324 milligrams of chewable aspirin. If the patient says that they can't take aspirin due to stomach problems or doctor's orders, call some medical control for guidance. Again, if you call med control, I suggest calling through dispatch, having them patch you in through the hospital or to the hospital. You can assist the patient in administering their own nitroglycerin if they're prescribed. And that's 3 doses. Total, separated by like 5 minutes. So if you give one, wait 5 minutes. If the blood pressure is still above 90, you can give another one up to a total of 3 doses. Something new in this protocol is EMTs can administer nitroglycerin from the EMS supply if the patient is prescribed nitroglycerin for this indication, chest pain or angina, and would normally take it in this situation. So even if they don't have it on them, you can give it out of one of the bags. So EMTs keep that in mind, so you guys will be able to give nitro as long as the patient has a prescription. Again, avoid nitroglycerin for patients who have taken erectile dysfunction drugs in the past 48 hours. Complete the fibrinolytic questionnaire, minimize your scene time as normal, and obtain a 12-lead EKG and transmit it to the ED. Preferably get that EKG as soon as you can once you get on scene. If you get called to a chest pain or anything that could be a heart attack, any symptoms of heart attack, so chest pain, shortness of breath, dizziness, syncope, anything like that, take your monitor and do an EKG almost as soon as you get to the patient. If the computer EKG interprets it as a STEMI, notify the receiving facility as soon as possible. It says EMTs may follow a STEMI destination pathway. Both Corbin and London are hospitals capable of managing a STEMI, so either hospital we transport to will be able to handle it. If a STEMI is suspected based on the EKG, apply your defibrillator pads to the patient's chest, preferably in the anterior posterior orientation, so in the middle of the chest and in the middle of the back. That goes for all levels. And then if you're below stroke, consider paramedic intercept. All right, moving on to the advanced EMT part. Pretty much the same. IV access, administered fluids to keep the blood pressure above 90. Nitroglycerin every 5 minutes. If symptoms persist, remember it's contraindicated if they've taken erectile dysfunction drugs in the past 48 hours. Treat nausea and vomiting per protocol, and then pain control. If the pain's not relieved by nitroglycerin or nitroglycerin is contraindicated, advanced EMTs can now administer fentanyl or morphine to chest pain. The dose for fentanyl is going to be 25 to 50 mics IV, IM, or intranasal every 5 minutes up to a total of 100 mics. And morphine's 4 milligrams IV every 10 minutes up to 10 milligrams. It's important to note for fentanyl and morphine, the dosages are a little bit different in the chest pain protocol as opposed to what they are in the pain management protocol. So advanced EMTs and paramedics, make sure you guys make a note of that. Remember that when you're on runs. The doses are a little different. My recommendation to advanced EMTs who are kind of new to giving pain meds or opiates, I would just go ahead and give a dose of Zofran with it. Oftentimes, it'll make the patient nauseous, so it's good to go ahead and just give that. That's what they do in the hospital. That's what I do on my truck, especially if they say they've taken it before and got nauseous. So just keep that in mind. Uh, Paramedics. Uh, Not a lot's changed for you guys. You can place the patient on the monitor, treat your dysrhythmia as PRN, and if you know a STEMI on the EKG, contact the receiving facility ASAP to activate the cath lab, transmit the EKG if possible, and consider going to the closest facility that can handle a STEMI. For us, that's not really a big problem. Like I said, St. Joe and Corbin both should be able to handle a STEMI.